So our today's topic is modes of mechanical ventilation. And before jumping on to our today's topic, we would start with the basic concepts of mechanical ventilation to set the ground first. So there are a few concepts that I would like to have clear to every participant. As you can see on the screen, there are two sets of information available on the ventilator screen. On left side of the screen is the information that we will have to enter into the ventilator, and this will determine the type of mode that we are about to give to the patient. And on right side of the screen, the display will show certain amount of data that is received from the patient end. And looking at this data and depending upon this data, we can either change these settings or we can change the mode altogether. So there are two types of data that is displayed on a ventilator screen. Now, the second concept is the type of breath. There are three types of breath. One is the mandatory breath. This is completely controlled by the ventilator. It is a controlled breath. The patient does not have a say in this. Then the second is the assisted breath. This breath is initiated by the patient, as you can see by this. You can see my arrow on the screen. Here you can see that there is a slight negative deflection before the start of the breath. So the breath is initiated by the patient, but afterwards it is taken over by the ventilator and it will assist that breath. However, the true spontaneous breath, the third type of breath, is initiated by the patient and is completely controlled by the patient. The ventilator does not have a say in this. At the most, we can add a certain amount of pressure support to it, but the breath is totally initiated and controlled by the patient. The third concept is the subset in a certain mode. If we are choosing a mode, we can choose a subset of volume controlled versus pressure controlled. At any point of time, a ventilator will either work in a volume control mode or in a pressure control mode. So at the top of the screen, you could see one of the most important equation in mechanical ventilation. This is minute ventilation is equals to tidal volume into respiratory rate. All right. And on left side of the screen, you could see that the settings that we will have to put in a vent for volume controlled subset mode. All right. So what happens is that we will have to set a certain tidal volume, a rate, and flow. And depending upon these settings, the patient will have variable peak inspiratory pressure. This will vary with every breath, and this will depend on many factors. But just for the sake of ease, I will take into account patient's lung compliance. So if the patient's lung compliance is okay, then a tidal volume of 500 may be achieved, and the peak pressure may be only around 15 centimeters of water. But if the patient's lungs get tight or stiff, then for a tidal volume of 500, the pressure may raise up to even 50, 60 or above. And this will put the patient at risk of barotrauma. Now, on right side of the screen, you could see the pressure control mode. In this, we have to set a peak inspiratory pressure, a respiratory rate, and the inspiratory time, the time the vent will spend during the inspiratory phase. And according to these settings, the tidal volume will vary, and this will depend upon patient's lung compliance again. If the patient's lung compliance is nice, then say, for example, for a peak pressure of 20 centimeters of water, the patient might have a tidal volume of 400, 500 ml. But if the patient's lung compliance is reduced, then for a peak pressure of 20 centimeters of water, the vent won't be able to generate a adequate tidal volume. It may be around 150, 160. So since we have already seen that minute ventilation depends upon tidal volume and respiratory rate, the tidal volume varies. So this will invariably lead to changes in minute ventilation as well. We do not have control over minute ventilation in pressure control modes. This is another important concept. If a patient has a problem with ventilation, then the two parameters that we have to adjust are tidal volume and respiratory rate. And we could adjust the minute ventilation as we've just spoken about that important equation. Minute ventilation is equals to tidal volume into respiratory rate. However, if the patient has an oxygenation problem, so we can either alter the fraction of inspired oxygen or the PEEP pressure. Although PEEP is written here, but what our target is that we have to alter the mean airway pressure so that it will improve oxygenation. Now, this is another important topic, and if you grip this concept, the modes of ventilation will become easier for you and will become more palatable for you. So, a ventilator has to know when it has to start inspiration. The phase of inspiration will be started once the trigger is reached. Just this is the same concept as when we pull a trigger of a gun for shooting. So the vent has to know when to start giving the inspiration. This is known as the trigger. Then the ventilator has to know that what should be its target. If it is a volume control mode, then the ventilator knows that this certain amount of tidal volume is its target and it has to achieve it. If it is a pressure control mode, then the ventilator knows that this is the peak pressure that I have to achieve. This is my target. So it is known as the limit, and it is something that is never exceeded by the ventilator as a safety mechanism. The third concept is the ventilator has to know that for how long it has to get inspiration, and after that it has to stop and go into the expiratory phase. So invariably, the start of expiration is known as cycling. Okay, so during any mode, a breath can be delivered either by the triggered either by the patient or it can be delivered by the ventilator. If the ventilator is starting a breath, it will always be time triggered. For example, if we have set a respiratory rate of 10 breaths per minute, so at every 6 seconds, a breath has to be delivered by the ventilator. So the ventilator knows that this time has been spent and now it's time to initiate inspiration. Volume triggering is not usually seen clinically, so we'll not discuss it. However, if a patient is starting a breath, it's triggering a breath, then it will be either pressure triggered or flow triggered, depending upon what we have chosen as a setting. Okay, so this picture shows on the upper graph that the dotted red line shows that this is the trigger, pressure trigger that has been set by us. Say, for example, it is minus 2 centimeters of water. So the negative deflection here that you could see, this is the patient effort. And as soon as it reaches this trigger point, the ventilator senses it that there has been a negative pressure drop in the vent tubing, and the vent will start assisting that breath or augmenting that breath. This is the similar concept with flow triggering, except that instead of a negative pressure drop, here the drop is in the flow in the vent tubings. So the vent will sense the drop in the flow in its tubing and it will initiate the breath. But the breath is usually triggered by patient and it is only supported or augmented by the ventilator. This is the main difference. So this chart compiles all these concepts. The first three modes, VC, PC, and PRVC, these are control modes. So we've already said that when a breath is controlled, when it is initiated by the ventilator, it will always be time triggered. So you can see that the breath is always initiated by according to the time in control modes in all these three modes. Now the mode is related to volume like VC and PRVC. It will be limited by the tidal volume that we have set in. All right. And if the mode is pressure control, the inspiration will be limited by that pressure. And how does the ventilator know when to stop the inspiration and start expiration? In the volume control modes like VC and PRVC, it will be the volume that is achieved, and then the ventilator will cycle into expiratory phase. However, in pressure control mode, the vent is given a certain time. If you remember, we will set an I time, which is the inspiratory time. So the pressure will be maintained in the patient's airway by the ventilator for that certain amount of time. And when that time limit is reached, this ventilator will automatically cycle into the expiratory phase. Now let's come to the spontaneous modes like PS, VS, and CPAP. In all these three modes, the patient will trigger its breath or initiate its breath. So we've already said that when the patient is starting a breath, it will either be pressure or flow triggered. Then If the mode is pressure related, like PS and CPAP, it will be limited by that pressure setting. And if the mode is volume related, then that limit of the inspiration will be that set tidal volume. Okay. And all these spontaneous breaths are cycled into expiry phase by flow. As soon as the patient stops taking in the breath with inspiration, there starts a decrease in flow. We call this flow decay. And this is sensed by ventilator, and then it will switch into the expiratory phase. Now, the SIMV mode is a combination of both these. There is a control breath given by the ventilator as well as spontaneous breath initiated by patient. So we'll see the mixture of both these things in the SIMV mode. Now we come to the main topic. First, we have to know what a mode of mechanical ventilation is. A mode of mechanical ventilation is defined as a predetermined pattern of interaction between a vent and the patient, or it is the relationship between the breath types and different phase variables. All right. So, although there are many modes available, the choice of mode is usually based on clinician's preference or institutional bias. And since the evidence is lacking that one mode is clearly superior to others, there are different practices in different hospitals. There are over 100 names for modes of ventilation on commercially available vents. Neither the manufacturing community nor the medical community has developed a standard taxonomy for modes. Furthermore, a mode can be named differently in different ventilators by different manufacturers. So the oldest type of mode was continuous mandatory ventilation or CMV. In this mode, all the breaths are given by the ventilator. This mode has total control to the ventilator. The patient cannot initiate or deliver a breath from itself, even if the patient tries to, the vent does not allow it. And there's a lot of asynchrony that happens in this mode. So this mode is now having the properties of assist control. In all the modern ventilators, you might see this term CMV, but what it has is that it has the inbuilt properties of assist control mode. So to reduce the incidence of asynchrony. The assist control mode is a newer mode, and it is the most commonly used mode. Whenever the patient is initiated on mechanical ventilation, most commonly this is the mode that is initially started. It has certain vent settings, plus a patient can initiate a breath. So it has the luxury that patient can initiate his own or her own breath. The vent will deliver a set tidal volume if it is a volume control mode, or a set peak inspiratory pressure if it is a pressure control mode. This is the typical graphical presentation of the assist control mode. Here, if you could see in the top and bottom graphs, you will notice that all the breaths look similar. The difference is seen in the pressure graph in the middle, where you could see the first, second, and third breaths are patient triggered or patient initiated. How do we know this? Because there's a slight negative deflection before each breath. So we know that these all three breaths are patient initiated. However, the fourth breath is ventilator initiated because there is no negative deflection and this is time triggered. This is how it looks like on a vent screen. Here you can see in the bottom, we can set the inspired fraction of oxygen, tidal volume, I time. This is the inspiratory time. A rate could be set. And here you can see that all the breaths look similar. All right. So this is the VCAC mode. So we have to set the tidal volume. Now this is the PCAC mode, and all the settings are similar except for the fact that instead of setting a tidal volume, now we have the setting of peak inspiratory pressure. And the vent will deliver the inspiration at this pressure and it will not be exceeded. The tidal volumes will vary according to patient's lung compliance, and so does the minute ventilation. This is another mode, synchronized intermittent mandatory ventilation or SIMV. Here we will set either the tidal volume or the peak pressure, depending whether it is PC or VC, and other variables just similar to the assist control mode. The patient can breathe spontaneously. The patient can have true spontaneous breaths of his own. This is in contrast to the assist control, where the patient was just initiating the breath, but it was assisted by the ventilator. Then the control was taken over by the vent. However, in SIV, the patient can have true spontaneous breath. It could be of variable tidals, and we can only support it with a pressure support of given value. In this, if a patient is initiating a breath just before a set breath is being delivered by the vent will synchronize with it, which means
नीचे वाला खोल हाँ भला
the vent will deliver a set breath along patient's breath a little earlier, and then the next cycle will start from there. So there is no overlapping, there is no fighting between the vent and the patient. This is how it looks like in VC SIMV mode. Again, there are all these settings. We have set a tidal volume because this is a VC SIMV mode. Then we have set a rate of 8. However, if you could see here on the second last box on right side, the actual rate is 15. So where does these additional breaths are coming? These are patient-initiated breaths. Okay. The backup rate of vent is 8. These are the planetary breaths which the vent will deliver according to the time. However, the additional 7 breaths are being initiated by the patient. These are true spontaneous breaths, and these are only supported with a pressure of 12, which we have already set in here. All right. Now, this is PCSIME mode. This is the same mode except for the fact that instead of tidals, now we are setting a peak inspiratory pressure. All the other rules apply to this mode as they were in the VC assembly mode. Now, how do we see a difference in a patient that is kept on a volume control CMV mode, assist control, or SME mode? There should not be a difference seen in all these three modes if the patient is not breathing, if a patient is paralyzed. We see the difference in these modes if a patient is having spontaneous breaths. Okay. So in VCCMV, the patient is trying to take breaths here, but these are not acknowledged by the vent, and the vent will not allow the patient to breathe or to initiate the breathe, and it will try to overcome it, and there will be a lot of asynchronous. Okay, this is the VCAC mode. Here you could see that the actual rate set here is 10, but the ventilator is showing a rate of 23. Okay, so these additional breaths are initiated by the patient, but you could see here, you could notice the difference that all the breaths look similar. They are similar in pressure, flow, and volume graphs because each breath is assisted by the ventilator. Although the patient is initiating a breath, but after initiating, the control is taken by the vent and all the breaths look similar. This is in contrast in the SIME mode. In SIME mode, the vent is delivering a rate of 10, but there are 16 breaths. So these additional 6 breaths are taken by the patient. And these do not look similar with the breaths delivered by the vent because these are true spontaneous breaths and these are being supported by a pressure of 8 through the vent. Okay. Then comes continuous spontaneous ventilation, and there are two modes that come under this heading. The CPAP and Bi-level. The patient's inspiratory effort is assisted by the vent at a preset level of pressure. So the patient can breathe spontaneously in both these modes. In continuous positive airway pressure, we can say that it is the exact opposite of continuous mandatory ventilation. In CMV mode, all the breaths were given by vent and the patient did not have its own breath. However, in CPAP, all the breaths are initiated by the patient. The vent does not deliver a single breath. However, the vent will only alter patient's breath by adding the pressure support, the setting which we'll put in. The CPAP mode is most commonly used to evaluate whether the patient can be liberated from the ventilator or not. This is the graphic you could see in CPAP mode. Here you could see that before each breath, there's a negative deflection in the pressure wave. This denotes that the patient is starting or triggering the breath, and there is a single level of pressure that is maintained throughout the inspiratory and expiratory phase. This is in contrast to the bi-level mode. The vent has set pressure changes. There are two levels of pressure and for two time periods. The mandatory breaths at higher pressure are time cycled. We will put a time setting and these will be maintained, the inspirative phase will be maintained for that time period. However, spontaneous breath can be pressure supported, which can take place both during the inspiration as well as the expiratory phase. So these are the settings that we will put in the PC bi-level mode. Here you could see that we can set a respiratory rate. F stands for frequency or respiratory rate. It's the same thing. So here it is 9 breaths per minute. Then we will set a PEEP high and a PEEP low level. This is similar to the higher pressure level and the lower pressure level. And then we will set either high time or low time. So here it is set that the high time denotes the inspiratory phase and low time denotes the expiratory phase. So we have kept a reading of 6 here. This means that the vent will spend 6 seconds in inspiration and then it will switch into the expiratory phase. This is how it looks like. You could see that there is a higher pressure time, then a lower pressure time, peak high and peak low. And during the inspiratory phase and expiratory phase, the patient can take his or her own spontaneous breaths. Now, these breaths can be supported with pressure if we have to add it. But the main point is that the patient can have spontaneous breaths apart from these peak high and peak low values. Now, what is airway pressure release ventilation, APRV? In this mode, there is again a set pressure changes. There are two pressure settings, P high and P low, and the patient can breathe spontaneously. The patient can have two spontaneous breaths, both during inspiration and expiration. This is how it looks like. Here you could see that we have put the value of, we can set an FiO2, a P high, pressure high, P low, then time high and time low. There is no respiratory rate setting in this. The respiratory rate will be set indirectly by T high and T low values. So this is how it looks like. The patient can breathe spontaneously during the inspiratory phase as well as during the expiratory phase. This is known as airway pressure release ventilation. So what happens that a positive pressure is maintained at a higher level throughout the total cycle time, except for a brief pause where the pressure is released from the airway. This is known as expiratory phase. And then again, that same high pressure level is maintained in patient's lungs. So how does the bi-level and the APRV differ? Although you could see that both have the same settings of two pressures, there is a high time, there's a low time. So how do they differ? Well, both are pressure control modes of mechanical ventilation, and you could use inverse ratio ventilation, and the patient can have spontaneous breath at the higher P low. Okay, but the basic settings are slightly different. In APRV, you will have to set a P high, P low, time high, time low. This is T high means inspiratory time, T low means expiratory time. We do not set a respiratory rate in this. However, all these settings are similar, but the terminology is different in bi-level. In bi-level, you set a peak high, this is higher pressure, this is lower pressure. And instead of setting both T high, T low, you can only set a single reading from this, either T high or T low. That means you can either set a time for inspiration or just for expiration. And then you have to set a rate. So in APRV, for example, if you are setting a T high of 5 seconds and T low of 1 second, so the total cycle time would be 6 seconds and the respiratory rate indirectly would be calculated to be as 10 breaths per minute. However, in bi-level, if I'm setting the rate at 10 and I'm keeping the inspiratory time or the T high of 3 seconds, so each cycle will be 6 seconds long. And if the inspiratory time is 3 seconds, then invariably the expiry time would be 3 seconds. So the total cycle time would be 6 seconds. And this will coincide with the respiratory rate of 10 breaths per minute. And in both the modes, the patient can take spontaneous breath both during inspiration and expiration. So on a vent screen, this is how both the modes look like. On left side of the screen, this is APRV. If you could see in the pressure to time graph, most of the time of a breath cycle is spent during inspiration. And there's just a brief pause in this where there is pressure release. And this is known as the expiratory phase. However, in BiPAP or bi-level mode, this is more of like conventional modes where you have a synchrony between the I and E time. Okay. So with this, if you've understood or grasped the basic concept of these modes, then I would like to congratulate you because all these modes have been discussed so far. And these are the slides which just summarize all the things that we have discussed so far. So I will just skip these for the sake of time saving. And then there are advanced modes, which is not our today's topic, but you need to understand that there are a lot of modes that are being introduced every day, but you should be familiar with the basic modes that we just discussed. So now let's do some brainstorming and let's see what have you taken with you from this presentation. The first scenario is that a patient is on pressure control assist control mode, PCAC mode. So since it's pressure control, then we have set a peak inspirating pressure of 15 centimeters of water, FiO2 of 40%, a rate of 20, PEEP is 5, and the I time or the inspirating time is 1 second. So would you like to comment that what would be the pressure support on this patient? You could type your answer in the chat box if you like. But the concept that I would like to clear here is that since this is a controlled mode, it is an assist controlled mode. So the patient will not have true spontaneous breaths. The vent will deliver mandatory breaths, which the rate is set at 20. And if the patient has to trigger a breath, so it will be assisted by the vent. These are not true spontaneous breaths. And when there is not a true spontaneous breath, we cannot apply pressure support to a controlled or assisted breath. Pressure support can only be applied to true spontaneous breaths. This is a concept that I would like all of you to have cleared. The second scenario is volume control assist control mode. So since it's volume control, we will set a tidal volume, which is 450 over here, a rate of 14, FiO2 40, and minute ventilation is 6.3, which is adequate. Okay, so then we took a sample and we saw the ABGs and the pH is 7.31, which is on the acidotic side, and the PCO2 is also raised, which is 61. However, the PaO2 and bicarb are normal. So how do we correct this? Now, if you remember the important equation that minute ventilation is dependent on tidal volume and respiratory rate. So we could either alter the tidal volume or respiratory rate. We could either increase any one of them or both of them to achieve a normal pH and to wash out this excess CO2. Okay. The third scenario is that patient is again on BCAC mode and the rate is of 12, FiO2 is 40, tidals of 450 because this is a volume control mode, so tidals has been set and a PEEP of 12 is given. Now the ABG results obtained show that the pH is 7.39, which is in the normal range. PCO2 is also normal, bicarb is normal, but if you notice that PO2 is decreased. So what do? We have already discussed that if there is an oxygenation problem, we either alter the PEEP or we increase the FiO2. So the PEEP is already at higher side. So what we'll do is that we'll increase the FiO2 to correct this PO2. Okay. And then to again emphasize this basic concept, this slide has been added that if there is a ventilation problem in the patient, we will alter the tidal volume and respiratory rate accordingly. And if the patient is having oxygenation problem, we'll either increase the PEEP or FiO2. Now, this is the final question. The patient is sedated and paralyzed. And looking on the graphs, can you determine which mode is this? Is it continuous mandatory ventilation, or it is VCAC, or it is VC-SIV? Now, we've already discussed it, that if the patient is
Dr.
paralyzed.
Mamoona, can I interrupt, please?
Yes.
As you have asked this question, I want everyone to answer this in the chat box. Let's wait for their answer. And we're getting answers. Mostly people are saying it's CMV mode. And Pradeep is saying that it's VC SIMV. and all others are saying it's CMV mode. So let's see what Dr. Mamoona has and what's the right answer. G, madam.
Okay, so this is the concept that I was trying to tell you, that if the patient is paralyzed, if the patient does not have any respiratory activity, all these three modes will act and look similar. Because in all these three modes, we will set a tidal volume and a respiratory rate. And these all three modes will look similar in all the three graphs of pressure, flow, and volume. The difference occurs when the patient has spontaneous activity. In CMV, the vent won't allow the patient to have its own activity, so the patient will be fighting with the vent. In VC AC mode, the additional breaths that are initiated by the patient will be assisted by the ventilator. So you will see that the breaths will all look similar, but some of the breaths will be triggered by the patient as shown in the pressure graph by a slight negative deflection before that patient triggered breath. While in VC-SIV, the patient-initiated breaths will only be pressure supported, and these will be true spontaneous breaths. So the crux of this slide or this scenario is that if the patient is sedated and paralyzed, all these three modes will look similar. I'm sorry that all of your answers are wrong. I would like to thank for your attention, and I hope this is not the reaction that I'm getting.
I am having another question. There is a concept of high PEEP and low PEEP. What is the difference? What is the difference between the two?
So the high PEEP and the low PEEP values are kept in the mode of Bi-level, which is pressure controlled mode in the vent. And this is the same thing as high pressure and low pressure as in the APRV mode, or in the conventional BiPAP mode, where we term this as IPAP and EPAP. But it is the same concept. You have a higher pressure setting for the inspiratory phase and a lower pressure setting for the expiratory phase, but you have continuously positive pressure during the total cycle time. Did you understand?
Yes, ma'am. Yes.
Okay.
Mamoona, I have a question for you.
Yes, sir.
As you mentioned, that patient was paralyzed and sedated,
Yeah.
and what was the graph was showing that which mode is that? So it was CMV or SIMV or SC control. I think, in my opinion, if patient is paralyzed and sedated, so all the modes will be behave or will work like a CMV mode. So you cannot
Yeah.
differentiate on graph basis. Maybe I'm wrong, but just
No,
want
no, sir.
clarification.
That was the point that was trying to clear to my audience, that it depends upon patient as well. If the patient is having respiratory efforts or not. So they should have this basic concept. The aim was to clear this point. You are very much correct.
But, so I think the question answer was CME mode was correct.
You cannot
If the
determine
audience
that.
was the
If you
CME mode,
Sir, if I've kept the patient on VC-AC mode and I've paralyzed the patient, how can you say that this is CMV mode? This is a trick question, and it is just to clear people's concept.
We have a lot of questions in the chat box. Let me finish them first. Someone has asked about, please, if you can briefly describe the indications for each mode.
Okay, so as I've already mentioned, that the most commonly mode that is initiated in a critical care unit is that of assist control. And the VCAC mode is the most commonly used. Apart from that, the SIME mode is used for weaning purposes. Although now the current literature and the evidence-based medicine suggests that the SIME mode is not ideal for weaning, and we should be using the CPAP or BiPAP modes for weaning purposes. Other than that, if a patient is having oxygenation problem, if the patient is having low PaO2 or SATs, and there is a lot of issue that the patient might develop barotrauma, we will be using the bi-level and the APRV modes, which are more ideal for the oxygenation problems. And CPAP is used for weaning basically.
Okay, someone is asking that how about the muscle relaxants for paralyzing? Which one do you prefer?
Again, all the modes that are now being designed are for based on this purpose, that there should be minimum interference from the ventilator, and the patient should be acting according to its own neural drive for respiration. And there should be minimum use of muscle relaxants, because very quickly, even after 24 hours, there is a beginning of the atrophy of diaphragm and weakening of the respiratory muscles. So the current practice suggests that you should be avoiding or minimizing the use of muscle relaxants. But in our part of, like in Pakistan, we usually have Acuron, Atracurium, and Rocuronium. So these are being used commonly.
Dr. Mamoona, I have a last question for you.
Yes, sir.
Can we use muscle relaxant in APRV mode?
Yes, you can use, but the purpose would be lost, because in this mode, we are encouraging the patient to breathe even during the inspirative phase of the ventilator. So that added benefit would be lost. Then why use the APRV or the airway pressure release ventilation? Also, there is this concept in the beginning of the era, there was the concept that the ventilator is the master, and the patient has to behave accordingly. But now the current practice is that the patient is the master, and we have to make the ventilator work according to the patient's neural respiratory drive. So these are the points we have to keep in mind.
One question for the mode of the there is one mode have been observing a new ventilator here, Mindray A9. I have seen one mode there with PCVG mode, pressure control volume granted. Any information regarding this mode?
Okay, so this is kind of a new mode. It is a smart mode. You could say it is a hybrid mode. I've already told you that a ventilator mode can only use either the volume control or pressure control mode at a single time. But this is a hybrid mode. It is an intelligent mode which could use the properties of both. So the pressure is regulated within the set values that we put in the ventilator, and we will set a target tidal. We do not set a exact tidal volume. We will set a target tidal volume, and the vent will sense the changes in patient's lungs, and then there's a closed loop. The ventilator will sense it and then again deliver a breath very close to that target tidal volume, and keeping the airway pressures between the set values that we put the information into it. So there is less risk of barotrauma, along with the minute ventilation is ensured. Both the advantages of VC and PC mode are taken into this mode, and at the same time, the side effects of both modes are avoided.
So, if a patient has bronchospasm or any airway restrictive lung disease, I'm
Yes, the
using pressure
patient
control,
has
but
you see, if a patient has a problem of compliance, this is a very good mode to use in those patients. Okay. Patients, those are overly compliant, like COPD and emphysema, or patients that are having stiff lungs and they have low compliance. You could use in both of these patients. So you take the advantage of both of these subset of modes.
Okay, ma'am. What is the setting in this mode, PCVG mode? How we will set the respiratory rate? How we will set the pressure or volume? Can you please explain?
I've already told you there are pressure settings that the vent won't exceed, and there is a target tidal volume. And the ventilator continuous takes feedback from patient's lung with every breath. This feedback is taken from breath to breath, and it is manipulated by the ventilator, and then a tidal volume is delivered according to the set target tidal volume. It won't be exceeded. The tidal volume would be around that value, and the pressure setting that we put in, it will also not be exceeded by the vent. It is a hybrid kind of mode.
I
Ma'am, with your permission, Dr. Danish, I'm working here in the Royal Hospital, Muscat. We are using this mode, pressure control volume guaranteed, in almost every paralyzed patient intraoperate. And secondly, we use another mode as well, pressure control volume guaranteed / SIMV. Both are added in the same procedure and same mode in case if patient has its own breath. It will
Yes.
be synchronized from the ventilator, so we'll avoid any synchronization between ventilator and the patient.
Yes. So, sir, this PRVC mode has two subset of modes. One that you have mentioned is SME, the other is assist control. So it has two subset of modes.